Welcome to this PCR interview on the Onyx ONE trial. The Onyx ONE study really looked at a complex and interesting group of patients. That is, patients who are at high bleeding risk and who are often also at a high ischemic risk. This is a group of patients that have become more important for us to study recently, and really where the focus has been on how we shorten DAPT and reduce the risk of bleeding in these patients. So in this study, in this interview, we'll be discussing and giving you some highlights of the Onyx ONE 1-month DAPT program. This will be given to you by Elvin Kedhi. And then we'll review some of the data from a sub-analysis comparing aspirin versus P2Y12 inhibitors after 1 month in these patients and looking at the data from that sub-analysis. These are my conflicts of interest. So I'm going to pass it on to Elvin right now, who will take you through some of the highlights of the Onyx ONE study.
My name is Elvin Kedhi. I'm an interventional cardiologist in Azeem, Bruges, Belgium. These are my conflicts of interest. As Azeem said, Onyx ONE was a randomized clinical study which occurred worldwide in 84 sites and had a very fast enrolling rate from November till September 2018. We managed to enroll 2,000 patients. The rationale of the study, as Dr. Latib already mentioned, was focused on a high-risk group of patients, particularly high-risk bleeding patients. In the last year, we've learned that bleeding is not such an innocent bystander as it's associated with a high risk of mortality, similar to that of myocardial infarctions, and therefore it has been paramount to very well study the duration of dual antiplatelet therapy in these patients, and particularly the high-risk bleeding patients. Recently, the BioFreedom trial have shown that a drug-coating stent, so a stent without a polymer, was very successful in reducing the dual antiplatelet therapy in up to 1 month in patients with high bleeding risk. However, other stents widely used worldwide and with very good efficacy as well as safety as drug-coated stents, between others Resolute Onyx, have also shown in previous trials very good results. And therefore, the question of this trial was, is this effect on these high bleeding risk patients, this superiority that we saw compared to bare metal stent with BioFreedom, limited to this stent, or it could be also the case for other drug-eluting stents, particularly with the durable polymer stents like Resolute Onyx. And therefore, this trial was performed. As we said, we enrolled 2,000 patients on a 1-to-1 randomization. And the primary safety endpoint was a combination, a composite of cardiac death, MI, or stent thrombosis at 1 year. We also looked to more specific stent outcomes by having a secondary endpoint, and that was a target lesion failure, which was composed by cardiac death, target vessel MI, or clinical-driven target vessel revascularization. Also, other endpoints like lesion and device procedure success were collected in the trial, the bleeding rate, as well as the complementary individual composites of the primary endpoints. These are the baseline characteristics of the trials. You could see there was somehow a higher age of what I've seen from previous trials, and this is due partly to the design of this trial. However, as you can see, the baseline characteristics are similar in both groups. There is a high percentage, up to almost 40% of diabetes in both groups, and also more than 50% of the patients presented with an acute coronary syndrome, being non-STEMI major, most of the time non-STEMI or unstable angina. In this slide, we represent the the high bleeding risk inclusion criteria. As you could see, the most represented high bleeding risk criteria were age more than 75 years and use of oral anticoagulation. As shown on the right side of the screen, you can see that the mean criteria for of high bleeding risk was 1.6 per patient, and that 46% of the patients had more than two high bleeding risk criteria. The trial was powered for non-inferiority. you could see that the Resolute arm, there was 17 point, the rate of the primary endpoint was 17.1, while in the Be of Freedom arm was 16.1, and the absolute difference between the two groups of 0.2. The upper sided 95 confidence interval margin was set at 4.1, and therefore we managed to reach the non-inferiority with a P4 non-inferiority of 0.11. Based on these results, the Onyx ONE got also the CE marking for use in high bleeding risk patients with dual antiplatelet therapy up to 1 month. Digging further into this data, we could see that here are the Kaplan-meier representation of the primary endpoints. The results are completely identical in both arms. These are the composite endpoints. There were no differences in, as I said, in the primary endpoint as well as in the cardiac death, myocardial infarction, or stent thrombosis, the three composites of the primary endpoint. However, looking deeper into this detail, we could see that for the stent thrombosis, the early stent thrombosis was at least double in the drug-coating stents. And interestingly, we saw also that we had a high rate of periprocedural MIs. This was due to the meticulosity of this study was performed. But interestingly, the spontaneous MI was significantly higher in the BioFreedom stent. If we look to a landmark analysis, what is striking is that at the moment that the patients were off dual antiplatelet therapy, so either with the P2Y12 or aspirin, there was a higher rate of myocardial infarction in the drug-coated stent. Here is the secondary endpoint as well as the composite of the secondary endpoint. Again, the stents performed equally, and there were no differences in cardiac death, target vessel MI, or cardiac-driven revascularization. However, looking also here to a landmark analysis, it becomes interesting to see that at the moment that the patients are off dual antiplatelet therapy, there is a high rate of target vessel MI with the drug-coating stent, with a significant difference here. On this slide, the bleeding rates are represented, and as you could see, there is a high bleeding rate, BARC 2 to 5, 15.1 versus 13.3, but however equal in both arms. Also, the BARC 3 to 5 was 4.9 and 4.4 in both arms, without showing any difference. Looking at this data, we could say again that these patients represent truly high bleeding risk patients, which, as previously shown, has a BARC more than 4, BARC 3 to 5 more than 4. So based on this data, the Resolute Onyx has now a CE mark for 1 month DAPT in high bleeding risk patients in Europe. These data are also recently published in the New England Journal of Medicine, and these are also visible online. I will now give the word again to Dr. Latib to give us some more insight about the sub-analysis of aspirin versus P2Y12 treatment after stopping of dual antiplatelet therapy at 1 month. Azeem, I give the word to you.
Thank you, Elvin. I think it's really exciting that in Europe you now have a CE mark for the Onyx stent for short DAPT. I'm hoping that here in New York and the US, we'll get FDA approval for 1 month of DAPT in the future now that we have the Onyx ONE clear results. One of the questions that still comes up often is that when you stop DAPT, does it make a difference whether you continue just aspirin or P2Y12 inhibitor? And as a result, we did this analysis where we took all the patients in the Onyx ONE study, irrespective of stent type, and we put them together, and then we divided them up based on whether they were taking a P2Y12 inhibitor or aspirin. So let me show you some of their data. So essentially there were 939 patients on aspirin versus 724 on a P2Y12 inhibitor. And as you can imagine, this was a sub-analysis of the study. And so there were baseline differences in the patient characteristics. In the aspirin group, there were more women, more patients with a history of chronic kidney disease, defined as a GFR below 40, and more patients numerically with previous MI. If you look at the P2Y12 inhibitor group, there were more patients who were on who had a history of atrial fibrillation or were also taking oral anticoagulant use, as well as having more high bleeding risk criteria. Now, if we look at really the antithrombotic therapy, and I think you mentioned this for the overall group, but I really wanted to concentrate on what percentage were taking aspirin versus P2Y12 inhibitor. So 92% were on single antiplatelet therapy at 2 months, 56% were on aspirin versus 44% on a P2Y12 inhibitor. And as you see, really the majority were taking clopidogrel, 91% taking clopidogrel at 2 months. If we look at 1 year, again, 88% were still on single antiplatelet therapy. Very similar percentages of aspirin versus P2Y12. And again, the most common P2Y12 inhibitor was clopidogrel. So I just briefly go through what some of the clinical outcomes were. And of course, we looked at the clinical outcomes between 1 and 12 months, excluding events during the first month when patients were on dual antiplatelet therapy. As you see here, in the dark blue is aspirin, and the lighter blue is the P2Y12 monotherapy. And if you look at the primary endpoint, which was similar to the primary endpoint for the main study, cardiac death, MI, or stent thrombosis, the event rates were very similar. Similarly, the event rates were similar for target lesion failure. We did, however, find a difference in cardiac death, with a higher rate of cardiac death at P2Y12 with P2Y12 inhibitors. And just a reminder, in the main study and for the sub-analysis, that any unknown death or a death where we didn't have enough information was attributed as a cardiac death. So we found a 4% rate of cardiac death with a P2Y12 inhibitor versus 1.9% with aspirin. It's also difficult for me to understand and explain this because the MI rate in the P2Y12 inhibitor was lower than with aspirin. The stroke rate was slightly lower. Stent thrombosis rates were very similar. Bleeding rates were also lower in the P2Y12 inhibitor group. And so again, all the variables that I would have been expected to be, other event rates that I would have been expected to account for the cardiac death were really not elevated. We did do a multivariable Cox regression to try and identify what were the predictors of the primary endpoint between 1 and 12 months. This is quite a robust stepwise model. As you can see at the bottom, there were a number of variables put in, and this is really what our final model showed. So the strongest independent predictors of the primary endpoint between 1 and 12 months was renal failure, like I mentioned before, clearance below 40 with a hazard ratio of 2.5, followed by hypertension with a hazard ratio of 2.9. And after correcting for some of the other differences, the choice of antiplatelet therapy medication was also predicted, with P2Y12 inhibitor increasing the risk of the primary endpoint. Femoral access prior MI were not significant. We also forced stent type into the model, and as you can see, the type of stent was not a predictor of the primary endpoint. So I think this sub-analysis is interesting and also poses a lot of questions. And maybe, Elvin, I'd love to hear what your thoughts are when you see these data.
Thank you, Azeem. This is indeed interesting data. I was also surprised to see the difference in cardiac death, and then again, after the multivariate analysis, to see that aspirin did better after correction for all the variables we put in this analysis. However, I have to mention that this was a non-pre-specified analysis, not powered enough. And somehow in this analysis, sometimes find results that are difficult to explain. Again, we should look to the general picture here. We have lower infarctions, similar, as I said, stent thrombosis, similar rates of stroke, and therefore is somehow not explainable why this cardiac death results higher in one group. And then again, that this cardiac death also drives the multivariate analysis into showing an advantage for aspirin. I don't think that based on these results, which remain hypothesis generating, we should then from now on decide to put patients on aspirin. This should be done based on patient characteristics. And however, what I also would like to say is that both groups showed in the end very similar results. And we saw a reduction in myocardial infarctions with P2Y12, in this case clopidogrel, and this is also not neglectable. On the other side, what I would also like to show is that very interesting for me is that the performance of these two stents, as well as the rates of bleeding in the, let's say, the landmark analysis you clearly showed, either with aspirin or clopidogrel, are similar and low. And this should not be, therefore, a reason that we as clinicians withdraw the chance of having an intervention to our patients based on the risk that they'll take from being on dual antiplatelet therapy or single antiplatelet therapy after that. So these are this is my opinion, but I'd like to hear yours too.
Yeah, I completely agree, Elvin. I think, what the message I take away, from sub-analyses is that they're hypothesis generating. They should stimulate further research. I think specifically with these data, it's worth taking into account that, there are a lot of confounding variables that we can't correct for. We try and correct for them. And so, there are things such as the site and, whether a high volume or low volume or high enroller, low enroller site, whether those play a difference into the event rates. I think, to strengthen this and to understand better the data, we will do a few things. So I think we can add the Onyx ONE clear data. So that's a single arm study done in the United States, and that will increase the sample size and the power of the study. And I think we can also, look at the narratives, try and get a better understanding of, some of the cardiac deaths and what caused them. Because as you saw, it's not clearly apparent why there was an increased risk of cardiac death. Normally, you see increased risk of cardiac death, and to explain it, you see increases in stent thrombosis, increases in MI rates, or in bleeding, which actually all went in the opposite direction, right?
Exactly.
So they may just be, one of the things we do in all these studies is when you can't get hold of the patient, you find either you can't, and you find the patient died and you have no information, by definition, you call that a cardiac death. And that may explain for some of these cardiac deaths. But hopefully, as we prepare a manuscript, we'll have more data in order to be able to share with our colleagues.
Yes, correct. And I want also to remember that by design, we did not specify who should get aspirin or clopidogrel. This was an operator choice. And somehow maybe some higher risk patients that we cannot correct for, the operator decided to put them on clopidogrel, and therefore we could see a higher risk of death in these patients.
I just probably reiterate, the important message I take away from Onyx ONE. It's that, we now have a modern, very deliverable, efficacious stent that appears to be safe with 1 month of DAPT in high bleeding risk patients. Okay. Does that mean we have to give 1 month of DAPT to every high bleeding risk patient? Probably not. Some patients may be able to tolerate longer than that, but it does mean that there's no reason to exclude patients with high bleeding risk from PCI or to use bare metal stents. We do have now a really good drug-eluting stent that is safe in these patients. And then the one thing I always like to remind colleagues about, even though after 1 month you see no differences in event rates between the two stents or depending on the antiplatelet agent, when you're going to shorten DAPT, the implantation technique is really important. So please, you have to do a good job at the initial procedure. Don't leave dissections, don't leave stents underexpanded.
No, absolutely. Also because if you look good to this data, these were not only high bleeding risk patients, but they were also very complex patients. This goes automatically most of the time due to the age progression of atherosclerosis. These patients are absolutely high risk PCI patients independently from bleeding. And that's why doing a perfect PCI work, it's paramount on these patients. I fully agree with that.
Great, yeah, excellent. So hopefully there's some important messages. We'll have some more sub-analyses coming out of the study to look at other subgroups. I think you're working on one looking at the acute coronary syndrome patients. And so I think as we move forward, there'll be more data on this interesting and complex group of patients.
This is indeed, we were satisfied indeed with these results. We have now broadened the gamma of the devices that could be used in these patients, and that makes the treatment of these patients now in a way more easy and with some better results. Also, as you mentioned, in myocardial infarction, that for me is still important to notice. with Onyx ONE. By this, I'd like to thank you, Azeem, for this nice discussion. I would like to thank the sponsors for organizing this meeting and also all the cooperators and co-workers in this important trial. Thank you.
Thank you.